Hi, everyone. Welcome to Thrive Tribe. This is the show that helps supports women through all the ups and downs from periods all the way to transitions in life and menopause, including fertility, pregnancy, postpartum, and more. And we are here dedicated to introduce you to amazing practitioners and different modalities that could really support your health and get you the knowledge that you need to start healing and feeling better and feeling your best. I'm so excited to have with us today Dr. Monica Xu. She's a naturopathic doctor here in Hong Kong. She focuses on longevity medicine, and that covers everything from hormones to chronic illnesses and chronic issues that you've been dealing with to really make sure that you're healing, getting better, and setting yourself up to thrive long term. And Monica has been practicing in Hong Kong for some time, but she's been practicing as a naturopathic doctor for over a decade. And she practiced also in the United States, where she also received her doctorate degree. So we're really excited to get all the wisdom that you have. Today, we're going to be talking about perimenopause. And actually, before we started recording, we were just chatting, and you were sharing a case study about one of your patients and about perimenopause. So if you could just maybe let's jump straight in, because I think sometimes hearing about a case or an actual person who's going through it can really help us understand what is perimenopause and how diverse it can be.
Mm-hmm. Yeah, so just mentioning earlier, it's more common than people think. So perimenopause changes can last for years. And this particular patient I just saw recently has hives or skin disorder that comes in. And I'm probably the fifth or sixth person she's seen so far for this idiopathic or the hives that come on with unknown triggers. And it's not really well managed with conventional medicine. So far on her own, she's gone through allergists, she's gone through GPs, she's gone through other specialists, endocrinologists to see what's happening, what's causing this hives, where in her particular cases, it's actually just rashes that comes on very itchy, very intense. It can come on randomly throughout the day. It can be mornings, it can be in the evening. She would be half asleep or getting to bed and it start itching everywhere and she just cannot get to sleep, right? And it really disrupts her quality of life. And antihistamine does help and it does quiet it down to a point that she can carry on with her daily task and just moving forward. But the bottom question is what's causing it? Why is she experiencing all these skin disorder that's never happened before, right? Not through her pregnancy, not through her periods or anything, just out of nowhere, all of a sudden she would start having this daily hives, it's multiple flare-ups throughout the day, quite disruptive. So that's why she was coming to see me to see if there's any alternative ways to look at this from different perspective to see how we can support her body. And so going into that, and when there's hives usually are secondary to histamine problems or immune system, where in her case, she came with set of labs. All her IgEs for environmental allergens, negative. Even though she's symptomatic, all her food allergen tests come out to be negative, symptomatic. Blood tests, nothing really we can put a finger on with the ones she's done so far. So we're just kind of like, okay, where is this going, right? In her case, we look at took two steps back looking at, okay, when did it start? What happened around that time? And also if there's anything else we can get any clues from. And in her case particularly, she hadn't really done anything different. It just came out nowhere. But she did have a bit of other symptoms. She called them a normal part of aging, just feeling tired a lot. She's called because she's a mom. So probably the kids and probably getting older, all the stress, and start noticing other things like her family starts telling her, oh, you're being a little bit short lately. What's going on? We notice a little change. You get a little bit moody sometimes. All these little things, she just called it, oh, probably just bad PMS, right? We typically just write it off and just power through like a warrior. But in her case, it just started becoming more noticeable before all these hive things coming out as a daily event. So we checked her vitamin status, especially vitamin D, which is critical for your immune system, and then her irons, her other blood tests, which I'm happy to go into later on. I think the whole point is eventually we got to the point where we find out, oh, she's actually in perimenopause, even though she has regular periods. It means that her period is still coming on every 25 to 28 days. That's why it never clicked that she is in perimenopause. And also you hear about perimenopause, you're like, oh yeah, it's much, much later, right? It's mid-40s or maybe late 40s. In reality, perimenopause can happen as early as in your mid-30s. And it doesn't always show up as the classic menopausal symptoms, because perimenopause, just rewind a bit, because I would digress a bit, but it's peri means around menopause, and a lot of symptoms you experience in perimenopause is menopausal symptoms.
Okay.
So another way to say it, people think of menopause, it's this motor response where you have hot flashes, night sweats, heart palpitations, or you have this sleep disturbance. All these can be present in perimenopause, but it depends on when, and also depends on your genetic profile, your background. So everyone's perimenopause experience may look a little bit different. And in people, so I categorize into different phases when it comes to perimenopause, right? The very early phase, you will still have your normal period. Everything else still just look like every day was a bad PMS. But you will have, in some people with history of migraines, you will have more frequent migraines or headaches. In others, you may experience neurological changes. It starts in the brain, because estrogen and progesterone, they are hormones that calms down the inflammation in the brain. So when you don't have enough, or when your body senses that there's a drop in these hormones, it shows up somewhere. And more often than not, neurological changes, mood, anxiety, focus, these are the ones that alters first, right? And
yeah. So just going back to her case, I think you said that she started getting moody just because, as you're just describing, the estrogen and the progesterone were dropping. And she also started getting hives, which is a surprising symptom. I've been hearing actually more and more about the fact that as estrogen becomes more unpredictable, it can also cause histamine releases, especially as progesterone, the calming, which is the calming hormone, can actually reduce, and that also stops keeping the estrogen in check, right? Or the hives in check. Is that the reason? Because I wonder, I think a lot of women don't associate histamine issues, like you said, to perimenopause.
It kind of tied back into how immune system is regulated. So it's not just defending yourself from pathogenic exposures, but also innately it's supported with estrogen and progesterone. Too much estrogen can elicit excessive histamine release from the body, and insufficient estrogen can also do that. So it's really hard to pinpoint, okay, this estrogen dominance or this estrogen deficiency that leads to it. But it comes down to balancing the hormones or balancing the response. So we can't really just assume one profile, hormonal profile, leads to this symptom presentation. And during perimenopause, it really differed, because different than guys where their testosterone just drops very slowly, 1 to 3% per year. Women's progesterone drops about 1 to 3% per year, but estrogen literally just goes through this kind of roller coaster. You don't really know it's going to be high or low, especially towards later stage of perimenopause. The early stage, when your body sensing there's a drop in estrogen, it will show either in, like I said earlier, in the brain, or it can show up in the joints, or it can show up elsewhere that's irrelevant to your reproductive organ, right? Because every time people think about estrogen progesterone, they always think about, oh, my period, or ovaries, or things related to breast cancer, less so for the general sense of where estrogen and progesterone plays in a role.
So I have a question around that. So I think something you just said that was really interesting, that a lot of people don't understand. It's not that your hormones are just dropping. They're becoming more unpredictable, because progesterone, you said, it keeps going down, but estrogen is like a roller coaster. And that's very tough, right? Because you just don't know how do you even then support a woman like your case that was going through that? Because if her estrogen is up and down, then how would you know whether to supplement with estrogen or progesterone?
Eventually we find out there's heavy metal toxin that's in her body that needs to get out first. So we did assessments, we did total body burden urine test to see what metals come out to be highest, and then we did a chelation therapy. And throughout, she noticed symptoms becoming less frequent, and there's a pattern that she can actually assign it to. So every time she does the weekly chelation, she noticed, oh, there's a flare up, but then it quiets down. So things do change. And so that's one thing, we lighten up the total body burden or the pro-inflammatory triggers in her case. And eventually it's to a level that it's manageable. It's more of, we expect it once or twice per week, but it's still quite not there yet. And that's when the estrogen progesterone comes in. And most of the time people can do the estrogen replacement or progesterone hormonal replacements, or you can do the botanical approach.
Okay.
Botanical, another name for it is phytoestrogen, means that they mimic what estrogen does in the body without looking exactly like the hormone itself. So that's kind of how we did to support her body. And because she's still menstruating, her body's still producing natural estrogens. We're not going to replace it in her stage where it's still, but when it comes to later, where your period becomes really spacey, or you start missing periods 2 months without a bleed or 3 months without a bleed, and that's a good time to consider working either with a gynecologist in Hong Kong to get on the hormone replacement therapy, which is great. There's lots of benefits. Or you can use the alternative, because not everyone respond well with hormonal replacements. So there are also botanical options to help manage the symptoms associated with having insufficient estrogens or having fluctuating estrogen levels.
Okay, so in her case, you didn't just stop at checking her hormones. You saw a lot of the IgE symptoms, IgG, all the allergies testing was coming up with nothing. But so then you did a toxin test, and that I helped you identify what was causing a burden on her body, triggering her immune system. And you did the chelation. But then you didn't supplement her with estrogen, you supplemented her with botanicals because she wasn't in the place where she needed that replacement yet because her periods were so normal. Yeah, so that really starts to highlight. And how did she feel after? Was she getting?
It went away.
Oh,
So
wow.
it literally went away in a month. But then the tricky part is it's not going to be the go-to treatment plan moving forward, because the estrogen level will continue to change. So we need to update her treatment plan, and we need to adjust whatever she will be taking based on symptom, right? And in the way that I did do labs, which rule out if there's any other issues, checking her FSH, checking her LH level, checking her estrogen levels. There are ways to see, okay, are these levels abnormal, or are they in high normal or low normal? So that's how I determine what phases she's also part of, where she is in the spectrum of perimenopause.
Okay, and where was she?
Still quite early, because when you see usually run all three markers together, so FSH, LH, and estradiol, typically in her case would be normal, so less than 30 would consider expected. You're not menopausal, it's more checking ovarian reserve, right? Just jumping around a bit. So when you don't have any more eggs left, that's when you become menopausal.
Right.
So day 3 is when we check these labs, and then we look at the markers. Usually less than 10 is optimal. Moving back a bit, so fertility, people with FSH and LH usually is 1-to-1 ratio. LH, luteinizing hormones. So usually it's 1-to-1 ratio. And so when they start to getting a little bit higher, because it fluctuates so much, I usually repeat in 4 weeks and just to see where they are. If they start creeping out towards upper 20s or 30s, then we kind of know, okay, it's struggling a bit, but it's not absolutely in the menopausal phase. And also you look at estrogen in ratio to FSH, because there's another hormone I don't really check for financial reasons. It's really expensive, and it doesn't provide any more information I needed to be. It's inhibin B. Inhibin usually rises first, and estrogen kind of correspond to that level as well. So back to the labs, right? If the estrogen is elevated, usually people think, oh, I have enough estrogen, I'm not near menopause. It's actually not true.
Right.
If it's more than, depends on which school you are, but anywhere in the upper 60s or up to 80s means your ovaries are really struggling.
Oh, because it's trying to push out a lot of estrogen. Is upper 60s or upper 80s considered high? Or is it just normal?
It's still in the normal range.
Okay.
But in my training, we consider that as part of you're getting closer and closer to menopause, right? It's still perimenopause, but in terms of fertility or how you are in a reproductive spectrum.
So if your LH is LH and your FSH is increasing,
right,
and your estrogen is also on the high normal side,
yes,
then actually you think you're fine, but you actually could very much be in the early stage of perimenopause. And is that what was going on with this client of yours? Okay.
Yeah.
So that's how you identified her in the early stage. And at that stage, you wouldn't do HRT or MHT as it's been rebranded, but as you told me, which is menopausal hormonal therapy, right? MHT. Yes. Okay. So you wouldn't do those, but you would do something like softer, like botanicals.
Especially when they're still menstruating, right? When they stop menstruating, or when it becomes too irregular, and that's when the treatment approach changes. And also depends on symptoms, which one is the loudest, and we usually mitigate the symptom that bothers them the most. So in her case, histamine was out of control, right?
Right,
And
right.
estrogen is one of the things that help to regulate histamine, same as progesterone. Because she's still ovulating, so we can use botanicals to stimulate how the body works. If she has no hormone left, then HRT would be the better option.
My question is, you said you look at primary estradiol, FSH, and LH on around day 3, right? When do you ever look at the progesterone or the testosterone or the DHEA in this process? No, you don't.
No,
Okay.
not so much when it comes to peri
Okay.
management, but if they have, let's say, PCOS, they have underlying issues carried over, endometriosis, for instance, or other parts, either fibroids or cysts in the breast, now look into more other markers. So it depends on the profile. In her case, none of these were part of the picture. Typically, I will stay with just a day 3.
Day 3, okay. Yeah. Otherwise, you would look at day 19 or 21 or something if you had PCOS.
If they were interested in fertility management, looking more into the day 19 or 20. But anywhere for peri or menopausal management, more so on the day 3.
Okay.
I'm aware and later on, if they are on HRT or MHT, they want to look at how their body breaking down the estrogen, or if they're metabolizing it correctly, and of course then we look at a different set of markers to evaluate.
I think something you highlighted, which everyone doesn't fully understand, that especially as women are becoming more and more aware of this, but there's still a lot of lack of education around menopause, right, and perimenopause, is that there is this early stage, and then there's a very clear and obvious symptomatic stage where you're getting hot flashes, your periods lengths are changing, the frequency is changing, like the period itself is changing. You're actually already in the middle stage of perimenopause. And then when you actually hit menopause, it's all gone. Basically, the period stops. That's when you've hit menopause. Is that right? Could you go through those 3 different stages?
So very early, you don't have much of period changes.
Yeah.
When it goes to early stage, for people who never had cramps, may start experiencing period cramps, even though nothing else really changed in your life, right? No change in exercise, diet. And they may also notice breast pain before their periods, which may not ever be an issue, or start getting worse if they had breast pain in the past. So increased level of pain, that's one thing that will show up. And also, besides changing cycle lengths, the amount of blood loss per bleed, and you may feel like, oh wow, it's catastrophic. Just I need to wear a period diaper. Otherwise, I can't go anywhere just because it's so heavy. So these are the things, because progesterone level drops, right? And progesterone usually is the one that prevents excessive blood loss during the period. So that's one part, that, okay, your body starts shifting, and other things, this big clots are coming out, and sleep may be one of the issues that people always overlooked because caffeine or stimulants. But if you start waking up like 3 a.m. or 4 a.m. just for absolutely no reason wide awake, you're not someone with sleep apnea, with other issues, you can't really go back to sleep. If that happens consistently, then of course you're getting closer to the peri phase, because the hormone playing a role here is your cortisol levels and your estrogen. So estrogen downregulates cortisol, and when you don't have sufficient estrogen to keep you asleep, then cortisol may take over, just one of the stress hormones will wake you up. So it is highest in the morning, but it shouldn't spike up when you're asleep. When it does spike up, usually other parts of the hormone pathway can help to calm it down a bit. Estrogen is one of them. So that's when people have interrupted sleep. And also sleep, when you don't have enough estrogen, then cortisol will shoot up, and you'll wake up and you think, oh, I need to go pee, right? That's the first response people have is, oh, I need to use the bathroom. But no, you just wake up for no reason.
Could it be any time, or is it always at 3 or 4 a.m.?
3 or 4, more common. It can be earlier, depends on what time you go to bed.
Right, okay.
But it's more of interrupted sleep in the middle of the night. That's one of the signs. If it recurs, it's not just one of all the blue. If start occurring throughout the month, not just before your period, you're getting there. Especially if your sleep was never an issue for you before, and now it start becoming one.
Yeah.
Aside from looking after other people, the babies or the kids, you just notice that you, for no reason, you're waking up.
Right.
Without the heart palpitation, without night sweats, and these are things that indicate your hormones start shifting.
You're in the earlier stage, but you're shifting. Okay.
Even though you still have regular cycles.
Yeah.
And that's when people come in. How's your period? Very normal, on point. Nothing is really bad, but my sleep is terrible. And other things people will notice is they don't associate with hormones, is change in your bowel habits. So one part, it kind of goes back to the histamine picture. People would start noticing they have slower transit time, so they're either choking on their saliva for no reason. They're just like, why am I choking on my saliva? Or they start choking on food. Oh wow, it's not going down. Or it's harder, it takes harder times to swallow those pills, and just drink a lot of water and feel like the pill is not going down their pipe. Or some people have this acid reflux where they never really had it in the past. They're like, why am I waking up with a mouthful of saliva? Or why am I experiencing heartburn in the middle of the night, right? All these, what we call digestive system symptoms start showing up for no reason. You haven't done anything much differently. Yeah. Exactly.
Why does that happen? Is it because estrogen is dropping? Or?
Partially, yes. Estrogen is partially to blame because it's part of the production. It helps you regulate your collagen. So later on, it becomes itchy and dry and all that. It's all from estrogen deficiency. Or when they start dropping to a level your body's sensing, oh, just not enough lubrication, not enough peristalsis with the pipe going down your esophagus, and other changes people may notice, especially if you have had those bowel habits change before your period, it becomes more pronounced when you getting into the perimenopause stage, where some people have more constipation, even though you're eating plenty of fiber, you're exercising, drinking water, do everything right by the book, you start having slower transit time. And there's no other explanation. People are looking at the food sensitivity. It's actually not food sensitivity. You know, dysbiosis actually still tests came out to be fine. Their inflammation, no, it's actually just the hormones that's supposed to push things forward drops, and that's when the body will pick it up.
What other than estrogen, what other hormone is a big deal for that?
Progesterone. Right? And that's when people get constipated.
Where
you can relate that back to the pregnancy. So some women have gut issues, they get constipation during pregnancy time, others may not. So it's really individualized. Partially hormones are part of the players. Not all, they don't take control of everything, but they do come in play. And other things like itchiness, I think I mentioned earlier. So itchiness, it's not just the skin, right? People are like, oh, my scalp is start getting itchy, or they start noticing their ears are getting itchy, and or eyes getting itchy. The thing is, allergy is not really allergy, it's lack of lubrication, and then your body become more sensitive, and other parts are getting itchy besides the skin, like just female reproductive parts. Vaginal itchiness, people think it's candida. It's not candida, but it can lead into vaginal candidiasis because of lack of estrogen, change in the pH, become less acidic, more alkaline, and all that issues. So it's actually everywhere. Estrogen receptors literally throughout. And if you're prone to have joint pain, right? A lot of people come, it's really achy. Where is achiness? Just I can't really explain it. Just throughout achiness, or just feel like puffy, swollen. You'll literally see cankles end of the day. These are all the changes that ties into hormone shifting, because progesterone is also diuretic. If you don't have enough progesterone, you may have quite a bit puffiness. And depends on the ratio to estrogen as well.
Interesting.
Those are the early stages of people.
And this can start as early as 35, right?
Yes. And anxiety is one of those things that people will go see a doctor for. These little things that bothers most women, but just not enough to bring them to see a practitioner. But eventually it'll just add up, right? They may not occur simultaneously, just one thing after another. It leads into the middle, or what's more vasomotor symptoms, where people have.
This is the middle stage you're talking about now. Okay, so that was the early stage. The middle stage is going to be more vasomotor symptoms.
Yes, so it's when people start going to ERs for no reason. So why do you go to the ERs? I had this panic attack out of nowhere. But the doctor says everything was right. We did all the labs, we did all the EKGs, we ran all the blood tests, everything was normal. But I just had this panic attack. So when you start noticing that in people in their late 30s, early 40s, it's the hormones part of the picture. And most often they're giving anxiolytic medications, right? The Razapam.
Which lytic?
Anxiolytics. So SSRIs, or if they're more depressive picture, then they give antidepressants just to manage the symptom, which is still part of the practice. But they don't realize it's actually changing their hormones based to these panicky attack, which never happened before, never in their family history, never in their personal life had this until they hit perimenopause. And they may look very normal from outside. They may look younger than their biological age, but inside the hormones start shifting, and they start irritating the nerves.
Interesting. Okay, so then you're going to have more vasomotor symptoms are one of the more unexpected ones during this middle stage as well, right? And the expected ones, I think they're the most obvious ones. Hot flashes, night sweats, changing periods, right? But there are so many unexpected things. And actually, something you described in that case that you just shared with us was she actually had an underlying issue, like the mercury toxin or the chemical toxins, or sorry, metal toxins, that were worsening her symptoms of reducing hormones as well, right? So your health beforehand has a big impact because basically the estrogen and progesterone shifts and testosterone shifts are going to worsen whatever underlying issue you have.
Things you kind of tucked under, not addressed in the past, will surface and they will draw your attention. It's like you can't ignore them.
Yeah. Everything comes to head. In your mid 40s or early 30s, mid 30s. Okay.
So when they're going closer towards menopause, right, they have had vasomotor symptoms, then their periods start getting really spacey before it's closer together and heavy, and now it's more further apart. Also, another part, going back to the period, some women will have period that never really stop. So bleeds 21 days, but the full bleeds, full flow will be just a few days.
Right.
The rest of the time just spotting, brown spots.
Okay.
But eventually the period will become really spacey. So you have maybe period every 3 months, or you have it every 4 months. Occasionally have a bleed. You don't know when you're gonna have your period. That's when you know, okay, you're getting closer to the hallmark, which is 12 months without a bleed. We use that as a benchmark to say you are officially menopause, which is only that one day. And afterwards, it's called postmenopause. So anything occurs after 12 months of no bleed, it's postmenopausal.
So during that mid to later stage where everything is really shifting in your period, that's when you want to do MHT or HRT if needed.
You can. Yeah, it's definitely a good option.
And I think this is where it's confusing. Do all women thrive or do better with HRT or MHT, or is it really just case by case? Because I think people are now confused. Like, do I do it? Do I not do it? Of course, my estrogen is dropping or it's going up and down, or my progesterone is dropping, but how come it's smoother for some people versus not? And then how do you know when you need to actually supplement?
It's really case by case because there's no two women with the same perimenopausal stage have the same set of response, right? But in general, it's quite safe to have HRT, and gynecologists have a lot of tools. There are different forms of HRT they can use, either bioidentical or with synthetic, because progestin, it's actually pretty good for women with heavy periods. Or I often refer people out to get IUD if they literally could not stop their monthly bleed, because eventually they will lead to iron deficiency, they'll lead to secondary issues, thyroid problems, a bunch of other things. Depends on their family history, their own health history. If they have either fibroids, for instance, they'll be more concerned, can I still put hormones in, because that estrogen will stimulate the fibroid to grow. But a lot of times it depends on the practitioner, right? When it's managed correctly, either with or without the botanical support as in adjunct to the HRT, we usually look at the person case by case. It's not one size fits all.
So it's really just like, how bad are your symptoms and how much can you handle them versus
mostly perimenopause is symptom management rather than a protocol. So postmenopause or in old days, people were more open to prescribing it.
Menopausal.
Yes.
So once you've hit that 12-month mark, people are happy to give you HRT more. Or MHT.
Yeah, more. Also, there are non-HRT approach because not everyone respond well to MHT or HRT, right? Some people will have it, try it, and they start bloating for no reason. It's just terrible. And remind them why they do not like it. And then, of course, we're here to support with alternative ways to balance out their hormones.
Right.
But it's not the one size fits all. It's a good option. And also there was a study that's debunked, not really debunked, but more well explained. It's the Women's Health Initiatives. And the hormones used there was mainly used to see if that can be used in prevention for cardiovascular disease, which is another part that comes much later on in postmenopausal women, where cardiovascular disease risk increase drastically. Means that if previously you have no high blood pressure, you may develop hypertension later on because of the lack of estrogen, lack of the elastic support in the blood vessels. And you may also develop or become more hypocholesтерemic, means you have high level of LDL, the bad cholesterol, or high triglycerides. People may develop fatty liver as a result of all these hormonal shifts.
Right.
So there are many changes that happens not immediately, but just added showing up later.
I think what's also a misconception is that perimenopause, okay, fine, it's this 10-year, 12-year period that I'm suffering, right? Or going through weird things that I need to make sure I take care of my health. But postmenopausal women are like, I'm done with my period. I don't need to worry about this anymore. But that's not true, actually, right? Your body is now in a new stage, which we like to call the second spring, but there is still stuff that you need to support and take care of. Could you share a little bit about that? So for postmenopausal women, it's not just, okay, I'm over the worst of it. There's a whole other world of things.
No, the symptom can last for years. So
Even postmenopause.
It can last. Some people will, unfortunately, don't have an easy time with it. They will still have symptoms 5 or 10 years out or 15 years out. So it doesn't naturally go away once you hit menopause.
Right.
It's just a benchmark. You no longer have eggs.
Yeah.
Pretty much your ovaries sensing that, okay, the body is aging because lack of the estrogen support. But the hot flashes may still be there. The insomnia may still be there. The dryness may get worse. The hair loss may get worse. The brain fog, the memory issues. That's one of the common complaints that people do not associate with hormonal shifts, especially in Asians. I would say depends on the family history, but a lot of patients I've seen here locally have more of the brain fog or unable to recall things or unable to integrate new things. I just feel like it takes so much more mental strength to do what they used to do and more ADHD-like behaviors, right? And then just thinking, oh, I'm just getting old, I'm just stressed out. You go to the kitchen, you forgot what you're doing, you come back and then you send the kids out, things start trickling in, but it's not so much of dementia. You don't have dementia. It's actually lack of estrogen and lack of progesterone and lack of these neural supportive hormones. Serotonin, that's one of them. And also people come in feel like really flat. I don't want to do anything, or I don't feel excited about doing things. You know, I used to love doing this and now I'm just like, you know what, I can go without.
Yeah.
Lack of dopamine was one of them, and the motivation was, and the serotonin is another one. We feel like calm, at peace, and just feel like everything's wonderful.
So then how do you help women in that stage a bit? Like, is it still HRT, MHT, botanicals, or?
Botanicals, or conventionally they have medications for anxieties and things that can help with depression. Depends on how severe the symptoms are. Some people don't respond well with pharmaceuticals, because I do have patients who really respond poorly. Then of course we switch them to alternative support called botanicals. One of my favorite ones is passion flowers and lemon balm. These are nervines, or things that calm down nervous system. And for people who are extremely fatigued in the mornings, 5 cups of coffee already. We look at their basic nutrients. Are they having sufficient B vitamins, all these minerals? And we look at their cortisol pathway to see how normal or how abnormal they are. So that's when the functional labs comes in place, where I rather test than guessing.
So what functional labs would you run on a postmenopausal woman? For example, the Dutch test a lot of practitioners use on perimenopausal or fertility-focused patients. But postmenopausal, there's no day 19 to 21 where you can run your Dutch test, right? And even perimenopausal, it can get very complicated to find the right dates. So what are you looking for those kind of, those stages?
In those transition stage, right, I look at how their HPA axis is, or how their stress response is. The more robust the stress response is, or the more normal it is, the easier the transition time.
It's all morning cortisol, night
That's the foundation. Without it, everything else is going to be chaotic.
What's tested in the HPA axis? Is it just cortisol, or?
So yes, salivary cortisol levels. And what I'm looking at is, do you have the normal rise and fall, and are they in range, or are they just barely hanging on the cliff, right? Where do you wake up fine and then they start tanking and then start shooting up with a little bit stress they experience, family stress, work stress, and that. So everyone has a little different profile, and that's what I look at first before getting to all the other hormonal supports. Progesterone, estrogen are helpful. If you have started HRT with a conventional practitioner and you start experiencing abnormal symptoms like mid-cycle spotting, even though you're on hormones, where you're not expecting to spot, things like that, or breast tenderness, or you have other hormonal related patterns. So we look at, are you making more of so there's 3 sisters of estrogen, right? So there's E1, E2, and E3. E2 is the one that's active, and that breaking down to 2-OH,
Right.
4-OH, and 16-OH. So the 16 is a more proliferative one. So if you have too much of that, we can push it away from the 16, look at the metabolites. And if you have more of the 4-OH, which is the toxic one, that tends to be associated with cancer or increase of abnormal estrogen-sensitive tissue growth, then we want to shift it out to the 2-OH. So adjusting how your body processes the estrogen, but not the key part of it. Mainly it's more symptomatic management. It's great to have it done at least once in your life, so you'll learn how your body naturally metabolizes.
The Dutch test you're talking about. Yes.
Right.
Yeah. Which tests the 2-OH, 4-OH,
Exactly.
16-OH, the types of estrogen. And
to actually learn your normal processes.
Right.
It's not in place where it's not diagnostic in lab tests, so it's not in place of normal labs.
Okay.
Even normal labs is not as unified decision whether the range is what we're supposed to do after. It's still based on symptoms. We use lab as a reference to either verify or confirm or rule out certain things. So that's kind of how I use the functional labs and in adjunct to conventional labs.
Okay. Can you talk about testosterone a little bit in women? Because this is a hot topic right now. And I think a lot of people are injecting themselves with testosterone from what I've been hearing, because it's becoming more and more known that women do need a certain level of testosterone. And in menopause or perimenopause, we do see dropping levels. And we see dropping levels in men as well because of all the toxins in our world and everything. So can you talk about a little bit the importance of testosterone and DHEA, I think also, because both of these are kind of unknown terrain, I think, when it comes to space. Yeah.
So in terms of androgens, right, these are all part of the androgen pathway. Some women do benefit having a bit more testosterone, but the cornerstone is not so much the testosterone hormone itself. It actually traces back to mitochondria, where all these hormones work on mitochondria.
Right.
I'm not against testosterone, but then again, with testosterone self-medication, there comes with risk.
Yes.
Things like deepening voice, or you may have excessive hair growth because they convert to DHT, or hair loss. And these are things that are irreversible. So most people are looking for the energy boost, which can be done through testosterone supplementations, or correcting, first of all, what's actually draining your body instead of just masking it.
Okay.
And testosterone is quite highly regulated, and it's not something that I take it lightly.
Right.
So the sister of that is actually DHEA, which is another longevity hormone. Surprisingly, most people have no symptom when a DHEA level drops.
Yeah.
And
my DHEA level has dropped post-pregnancy.
Yeah.
Yeah.
And in terms of energy levels, it's actually not, I would say in women, you don't really see much of a shift when you do supplement DHEA versus you don't supplement it. In men, it's quite a bit different, where they will notice a shift in their energy levels, in their mental focus, in their drive, less so in women, clinically speaking, from my own experience. So it's one hormone is good to have in check with cortisol. So it goes back to, I use them as a pair, right? When you have too little cortisol or too much cortisol, you always want to check where your DHEA level is. Some people have very low DHEA, means they could benefit from supplementing it. Some people have natural high DHEA level. In this case, just leave it alone. I don't want to optimize it, because optimizing the level is different.
Testosterone and DHEA are both working around the mitochondria and energy boost, and that also starts to decline during perimenopause.
Absolutely. Yeah.
Okay, so that also starts to decline.
So you actually change how you exercise. Yeah. What bothers me the most is people still exercising like their 20s. Yeah. You cannot have the same set of exercise.
Yeah.
You cannot just be a cardio bunny and think you're going to burn through all the calories. Does not work the same. You don't have the same number of mitochondria in your muscles. These level drops, that's where you feel the fatigue instead of getting this boost, right? You just get this ongoing achiness, and you push yourself to keep going, exercise, hit the target, be disciplined. It's actually quite different when you hit perimenopause. I think a lot of women are adapting to this. It's actually adding more weight trainings or resistance training to build the muscle. One of the concern women have is, am I going to get really bulky? I don't want to be those chunky ones. It's really difficult. You don't have enough testosterone, first of all, to maintain it. It's hard to even build muscles for women, let alone become really bulky like those bodybuilders. They put so much work into it.
Right.
Building the muscle strength, and also that helps to build your bone density. And anything that's a bit more, I call it impact, either jumping or running or anything that have a direct stress on your bones can help prevent bone degeneration, means less likely going to early osteopenia or osteoporosis.
So you're saying running will help?
Yes,
even
jump ropes, right? So anything that stresses the bone, that's how they rebuild.
So it's more like HIIT rather than long cardio sessions. Is that what you're trying to say?
Right. Long cardio can look different for a lot of people.
Yeah.
Biking can be long cardio, right? So it depends on the preferences, but I prefer people mixing in the weight training. The earlier you introduce it, the easier to carry it forward.
Right.
It's very difficult for postmenopausal women in their 60s start weight training. Doable, very doable, very difficult on the joints, very difficult to kind of stick with that habit. So the earlier you introduce the weight training, the better it is. Because not having enough hormones, partially the body, besides the mitochondria part, I think the body does not, it's growth hormone is one of the hormones that declines with age. And that's all these other catastrophic changes.
The insulin growth hormone specific, right?
IGF,
IGF, yes.
So that's the one I used to measure as one of the markers to see where you are in terms of the aging spectrum. But that does drop with age as well. Surprisingly, some people don't. And so what makes it robust is actually a good night of sleep. So it goes back to having a solid night of sleep. That's when your body makes
protects your sleep at all costs.
Exactly. So the same thing for testosterone in guys, right? If this is women's topic and divert a little bit, but for guys, testosterone are made at night. So if you sacrifice your sleep for work, for other reasons, your body will take a toll. It will show.
That's why new parents are so broken.
Exactly. So having good night's sleep can really, not only it feels refreshing, but it really resets a lot of the inflammatory changes and it helps to regenerate your bone marrows, the immune system, in a sense where your white blood cells are not tanked. And I've seen over and over where people who only live on 4 hours sleep, right? 5 hours sleep, and their white blood cells are tanked. It's not symptomatic. They're fine. They're not getting sick. But when it comes to overall health, it's not, we don't advocate live on 4 or 5 hours.
I'm going to go in one slight direction that I've not actually talked to you about, but I wanted to ask you about autoimmune conditions, especially in women, right? Because women have much higher autoimmune conditions, like much higher rate, of autoimmune conditions. And many women, they of course it happens in their 20s, but also we're seeing a rise of it post-menopause. Right? You're seeing more women post-menopause have more autoimmune conditions. And a lot of them are digestive immune systems and autoimmune conditions. And you said something about how your estrogen controls your entire motor, like your gut motor reflexes a bit as well, right? And keeps it lubricated and stuff. So is there a connection there, or what is going on there?
Estrogen part of the picture. So I've seen clinically people with rheumatoid issues, right? The markers are extremely high. Try conventional things and then decide not to go on a biologic. Give it a try for hormone therapy for them out. For hormone replacement, some cases it really drops these autoimmune antibodies.
Really?
Hashimoto's another one. Graves is just the common ones. Partially, there's not scientific research to back it out, but women do have more neurological stress than men. I think that does kind of present itself after you lose the protection, right? You lose the estrogen as a protection. You lose the progesterone as one of protections. So I think just flares out. I don't have enough scientific research to back the statement out, but I think partially losing these hormones really dampen your immune system.
Yeah, because you're basically being kept afloat from the autoimmune conditioning resurfacing itself. And then those protective hormones, as a theory, are leaving your system, and then everything that was just underlying worsens. Such a high rise in autoimmune conditions also post-menopause.
Where even peri starts showing up, right? These autoimmune markers.
I've seen it with my own family where suddenly autoimmune, or friends, parents or moms, suddenly they've developed autoimmune conditions in their 50s or 60s.
And it's not out of nowhere. It literally accumulates, and they have signs earlier on just being dismissed, right? And that's another reason where peri or menopause women get pushed around or just get told, oh, you're too young to have this, or oh, it's it's something you can just take a pill for, painkillers, for instance.
Right.
Just because it's not recognized enough. And autoimmune is one of the issues. And the other one is cardiovascular disease. It's huge because it's number one killer still, not just in the States, but I think worldwide. Women have a lot of heart issues.
Yeah.
And even though women do see doctors more often than guys, but it's still one of the risk factors because you don't have estrogen to help excrete the cholesterol. That's only people. Another sign I see, even they don't have any neurological symptoms, they have no change in the periods. When I start seeing their cholesterol level doubling or jumping, 30 points, when they have the same consistent diet, I know something is changing.
Right.
When they develop not diabetes, but when they have a bit trouble managing their sugar, and when you see the average hemoglobin A1C, which is a 3-month average marker, start rising, all these are changes that can occur even though you don't have physical symptoms. And weight is another part, and start noticing that redistribution of fats,
around the gut,
especially in the middle of the donuts, right? And it was like, I do so many abs, I eat low carbs, I have the broccoli diet every single day, but it's not going away. So that's when you know it's start having perimenopause. You are in the perimenopause. And later on, we can redistribute it with GLP-1. It's one of the famous where hot take for people who have weight issues. The GLP-1
and
is
what was
great.
the other one you said?
Just leave it GLP-1. And alternative to that, there's not a whole lot. But diet and exercise is a basic foundation.
Okay, great. I'm just going to quickly take a look at what else we have, because I know we are coming to time. So I think what you've been highlighting is that taking care of yourself in this perimenopausal time is so important, but people don't understand how important it is. Because like now we just talked about all the things that can hit you postmenopausal, right? Like autoimmune, cardiovascular, all the things that you underlying can show up even more during perimenopause and postmenopause. So what can women in their like 20s and 30s do to get, if you're a woman in perimenopause, come get help, right? Like that case study you shared with us, you were the 5th provider that she came to, right? And she went to allergists, endocrinologists, many more, and she got lucky to find someone like you who was more aware of the perimenopausal state, right? Or she searched and did her own research. But so for people who are in their like mid 30s to late, know that you could be in perimenopause. Don't ignore the signs, fix the underlying conditions and all that stuff. But what about women earlier? If we have some listeners who are just learning about, hey, this is a stage that I'm going to go into my life, but my 20s and 30s, how can I set myself up better? Well, what's like a couple of the most important things I could do?
I'll say 20s, don't worry about it. Live your life. Don't stress over things that hasn't happened. But if you do have a really bad PMS, PMDDs, low cravings, do get these symptoms addressed. Especially when we have irregular periods or there's underlying women's health conditions already, do not ignore them. PCOS, for instance, even though it's not bothering you. Just because it's not bothering, do not ignore these. As early 30s, you may want to prep your body because alcohol do not hit you the same when you're in your 30s. You cannot just have a night out and then still function the same way. You have longer time to recover. So it's either you choose the drink or you choose to sacrifice your sleep. So just habit-wise, you really have to fine-tuning what you are willing to sacrifice for. And in terms of diet and exercise, I think most people have quite a good awareness, at least 30 minutes exercise 5 days a week, just to maintain the body weight. And some people come in, I'm not losing weight, but it's stuck in their early 30s. Partially it's because the output, it's bare minimum, means that 150 minutes per week is bare minimum. The new guideline shows up, it's telling people it's 300 minutes per week. It's where you need to hit to actually have weight loss, which is quite high. That's why I support the weekend warrior theory, right? If throughout the week you cannot fit in an hour per session 5 days a week, you can do a long hiking day, or you can do a long extended exercise session so that you not stress over not hitting that 300 minutes. So these are basic things you can do and work on the food intake, recognize what are the triggers. Some people have gluten issues, some people do not have gluten issues. Just be more aware of what you put in your body. And so typically I say, even though I don't want to have people start taking supplements for no reason, but I would say fish oil is beneficial for most people. especially if you do not eat fish 3 to 5 times a week, because the anti-inflammatory benefits you get, and also it protects your brain. It downregulates all these, I would say, damaging signals. So that's something that you can consider adding to your daily toolbox, if anything. And having regular bowel movement. Do not ignore if you do not poop for a whole week, right? That's a problem. Just basic things you can easily write off, but eventually becomes a problem later on.
That's such good advice, because so many people, when I was in my 20s, I have the worst period. I'm just out for 3 days. And they don't think about it. They're just like, that's just my period, right? Or I'm just depressed and moody around my period. But no, you don't need to be, right? So get to know your body and figure that out at the young age, when you're not dealing with changing hormones at the same time, right?
Exactly.
Yeah, that's such great advice. And then I love that you said figure out what are your triggers are, right? Like your food allergens, what are you sensitive to, and address those underlying conditions earlier, so that you're entering that stage in your life in a better way. So it's not about worrying about that stage, like you said, but it is about just making sure that you're aware of how your body works and how you need to function. And of course, exercise, like you said, that's great. I love that advice.
So the question I get a lot is people are asking, what does perimenopause feel like? Right? And they'll come in their 30s. I just get my annual and I just want to know. I hear this social media, everyone's talking about it. I would say take a look at what happens before your period, that 7 days or 10 days. It's a pretty good picture of what you will feel like in peri. So if you have really lousy one, if you have really lousy PMS, not going to be a fun ride. So just embrace that, have realistic expectations. Someone are very blessed, they have nothing. They just go through their days and have their period, no pain, very blessed.
Swelling.
That's when they come in, they're like, I had probably stopped my period maybe 5 or 10 years ago. Nothing, no hot flashes, no light sweats. They have very easy transition. So it's very different. And now we use a little window before your period as a reference, because that's when your hormones tank the most. And it's when your estrogen is the lowest. And it happens more often than not during the peri phase than when you have regular periods. So that is an indirect.
That's really good advice, because it's like, what could perimenopause feel like the week before your period? And actually, how do you know you're in perimenopause versus PMS, PMDD? How would you be able to differentiate between those things, or is it very difficult?
Timing. Timing is everything, right? So PMS, PMDD typically happens before your periods or around ovulation time. That's when the hormones start shifting a bit. But it goes away after ovulation, or it goes away after you start your periods. So it's really predictable. When you start having symptoms really random, I'm not ovulating, but why am I having this rage? It's nothing that should be bothering me. You just need to get it out, or you have this feeling that you just feel anxious about something, or you're so distracted, you cannot get anything done. You start 5 projects at once and none of them get finished. All these, if it happen more and more often, not around the period time, you kind of want to take a step back, hard things. They might be in the early phase, very early phase of peri. And that can be, like I said earlier, in the mid-30s, because average age is 47, right, when people hit menopause. So it can happen 7 to 10 years prior. So do not dismiss those, and look for support to help mitigate the symptoms. There's not a whole lot you can do to correct your hormones, unless you want to be on birth control, unless you want to be on these IUDs, which help some of the symptoms. But alternatively, this is a great place where we step in, nutraceuticals, magnesium, where you can have things that manage these swings. Botanicals can help prevent the extreme dips for people who feel very low, or too anxious to sleep, or have these ruminating thoughts. So all these can be supported without using hormones.
I think one thing to tell people to do in this is to go to a naturopath, or who would they go to for this? I guess that's the question. How would they get diagnosed that they're in perimenopause? Because you said, I think what we talked about is self-diagnosis can be tricky too, or dangerous, right?
Yeah, so perimenopause is not diagnosed by labs. Labs are used as reference. More clinically, we diagnose perimenopause after we rule out all these underlying issues, thyroid, iron deficiencies, or other uterine diseases. And then, then you're probably in a peri. But even with just symptom management. Self-diagnosis, it's a little bit tricky, because you may have blind spots you miss, right? And things that can be done through imaging or lab tests easily provide an answer, a clear treatment path. So that's where it's really good. I encourage people to go online, learn about these informations. But when you try, it's more of confirmation bias, is how I put it. You look for something and part of it, and you think that's got to be what it is, and you miss all the other elements. So it's helpful to have another set of eyes to look at what's actually going on. And for us as naturopaths, we provide continuous care, right? It's not just one visit. And if you have symptoms, we give you remedies, then we try to see how are your body responding to, and you can always come back later on and we can do continuous care rather than seeing 5 providers and nobody really talks to each other. The list of medication, you're like, am I supposed to continue taking this? Can I stop this? And no one really give you an overall review of what's actually happening.
That's great. This has been such an interesting conversation for me, especially as I'm turning 40 this year. So what's one piece of empowering advice you can give every woman who's approaching?
It really looks different person to person, but I think it's a chaotic phase where people are not sure, going in blindfolded. Just know that there are symptoms that can be managed conventionally or unconventionally. Also, it will power through until they hit the very late stage, and then they come in, right? Come in early, and then you can get the support. And also look at it as instead of midlife crisis, that's a lot of times what people are experiencing currently. Look at it as a way to empower yourself to grow, not just knowledge, but also to support your body. You don't have to go through this alone. We're here, we're all in this together.
I love that you said that, because I heard you say a few times the warrior mentality or warrior through this. And that's such a woman's mindset, especially once you have a family or even before that. But when you have a family and you have children, you have people relying on you, just like warrioring through all your symptoms and all your problems and just handling everything. But there is help, and you have a whole womanhood around you, right, to support you through this. So don't warrior through it.
No, talk about it with your friends and see other people. Actually, it's okay to talk about it. It's not a taboo. It's not something we just shush about.
So get the help you need. Thank you so much. Such an enlightening conversation. Thank you for your wisdom.